I'd like to welcome everyone to today's webinar, The Lost Tribe of Clinical Data, a dramatic story based on real-life events. My name is Samantha Holvey, and I'm the Director of Community and Education at WEDI. Thank you for joining us for today's webinar. And before we get started, I want to take a moment to go over just a few administrative details. As you have noticed upon joining the webinar, everyone has been placed on mute for the presentation. At the end of the presentation, there will be a Q&A session. In your GoToMeeting control panel, you will see a questions box. Please type your questions or comments into the field and hit enter. You will also see a handouts box, and the slide template or the slide deck has already been uploaded, so you can go ahead and download the slides. I know everybody's always very concerned about getting the slide deck, so it is already available for you to download if you would like to. We'll also be emailing everyone the link to download the recording of the webinar as well as the slide deck. Without any further ado, I'd like to go ahead and introduce today's speakers. You can go to the next slide, please. We have John Kelly, Principal Business Advisor, and Sergio Rada, Senior Director of Product Management. Both of these gentlemen are from Edifex, and I'm looking forward to what they have to teach us today. So, John, I'm going to hand it over to you.
Thank you, Sam. Appreciate that. And I want to thank everyone for taking time out of their day to spend a little bit with us, and hopefully you'll find what we have to present interesting. We're going to cover a little bit about this idea we're calling, humorously, the Lost Tribe. Some of the drivers that we're seeing, our customers, many of whom are payers looking to access, acquire, connect with their network around clinical data. Some of the key factors to consider when you are looking at how to engage with your network around the idea of clinical data exchange. And then we'll talk about some smart approaches to either ramping up your existing clinical data interactions or starting from scratch and really trying to reach out and take advantage of the emerging set of clinical data that's becoming available as a result of so many providers adopting electronic health records. And then, kind of we'll talk a little bit about how do you design success no matter what approach you take and no matter how you're going. Then we'll provide some time for some questions. Next slide, Sergio. So if you'll bear with us, give us a little latitude here, kind of invoking a very old metaphor of the lost tribe, relating that to the idea of clinical data, and thinking about clinical data as it's been discussed, that we see our customers, a lot of the industry, the folks that we're talking to, talking about clinical data as something separate, unique, different, that requires a whole new type of IP, a whole new type of infrastructure and architecture, and really something other than what you've been doing historically to exchange data between payers and providers. Our view of clinical data, in a sense, is that it's really all patient data, whether it's data that you've acquired from claims, prior auth, referrals, all of the different HIPAA type transactions, X12, labs, NCPDP, that HL7, FHIR, the new emerging standards, and what we call clinical data is really just a different format. It's still all about the patient. A patient sees a doctor. And so the idea that, we all used to be one, that there's a group, each with its different flavors, there's something special. There are some idiosyncrasies about lab data or about EHR data and HL7 and FHIR, but in reality, they're all kind of tribes within a large clan. And that at a kind of point in time long ago, one type of this data, one tribe kind of split off, and that we're now at a point where we're trying to capture that back in, that we've lost some important meaning and we're trying to bring it back into the whole. So we kind of, used a playful metaphor, though, to try to get across a serious concept. Next slide, Sergio. So in our view, looking at, stepping back from what we see today and how the market has evolved, the idea of the third party really began a separation. When you think of going back to, the early days of modern medical care in the early 20th century. Doctor saw a patient, they discussed, shared a lot of information among two people, and then all of that information was contained in that relationship. And that then the doctor said, okay, this is what I'm going to charge you, and the patient paid the doctor. And so, everything was together, everything was a whole. The minute we introduced the notion of a third party, an insurance company or some other entity paying for the care, we effectively split the data streams in healthcare. We had one set of data that was being accumulated specifically for reimbursement, and we had another set of data that we now call clinical data that was being accumulated specifically for the delivery of the care and supporting the physicians and the patients and actually, treating illness and getting better. And over time, that became very regimented, very rigid. We had a complete, one administrative data stream that became automated and digitized and formatted and development of standards, and then a completely separate data stream that's being stored initially on paper and then slowly over time moved into the computerized patient record, which we now call the EHR, the EMR, the connected patient record, whatever term you want to use for it. But, to a great degree, when we started looking at the patients and we started kind of mashing up the responsibilities for who's taking care of the patient, who's managing the care, who's ensuring quality, suddenly different people weren't looking at the patient as a whole. They weren't looking at the full picture, and more and more, the most important data that was necessary for people to do their jobs, whether they were on the provider or the payer side, was on another side of the fence. Providers didn't have access to the full range of claims and remittance and prior authorization data that the payers had. And more importantly, when payers are trying to begin to incent providers and share risk, they don't have access to the labs and the CCDAs and the FHIR and the data that was stored in the clinical record. So in the NFX view, the differences between what we call clinical information, what we call administrative or financial information, is not so much in the nature of the information itself or what it's describing. It's about a patient seeing a doctor or an interaction between a patient and the health system. But it's just more about how was the information captured and where was it stored. And that's really what differentiates. There's no real difference in the content itself, in the nature of the information. It's really all about the patient. Next slide, Sergio. So, I think we've seen a lot of evolution in the last 10 years of the deployment of EHRs and meaningful use and all kinds of investment by the government. Probably maybe over $100 billion has been invested in the deployment of digital patient information in the last 10 to 12, 13 years. And largely payers have sat on the sidelines. The development of the HIEs, some payers are taking advantage of, but largely it's been more about doctors communicating with doctors. And that's what the development, the evolution of the patients, even among the HL7 community. When HITECH first started, there were 4 use cases, very much of it involved in Medicare's view of what the future of value-based payment would be about. But most of the investment was dealing with doctor to doctor, doctor to patient, and continuity of care and connected care case studies. They really weren't looking at, well, what about that value-based stuff? What about the payment stuff? And the lack of trust between the communities was another barrier to sharing information about the patient. So even though we were working on all the technical stuff, the business cases and the trust factors and the contracting really wasn't in place. Well, here we are in 2018, coming up on 2019, and suddenly the incentives, ratcheted up by CMS and MACRA and things like that. The pressures that have never gone away around the costs and the quality of healthcare. Suddenly, there's such a huge demand that, EDIFX is a company largely dealing with payer customers, and our payer customers are coming to us constantly over the last, say, 12 to 18 months and saying, okay, it's time. It's time for us to jump in. And so what's driving that is we see, there's the claims attachments and prioritization stuff has always been there, but that the cost pressures and the utilization and the control and the risk pressures have pressed that up. But also HEDIS and STARS measures. HEDIS measures are critical in terms of all of the payers that have gone into Medicare Advantage and managed Medicaid. they get paid based on an accurate representation of the illness of the patient population. And what payers have found is that largely they're missing data, that in the coding process, in the sharing process, in the submission of just claims to get paid, there's a lot of diagnoses that don't get reported that would actually increase the revenue to the payers, the premium they would get to adequately cover the cost of the care. And the STAR measures in terms of competing in the marketplace for quality, having all of the information both from that was captured in the EHR as well as the revenue cycle systems, having in creating that big picture can have a huge effect on the STAR rating of a plan. So, the acquiring of this clinical information directly hits, bottom line revenue through the HEDIS measures and top line growth when the payers are competing in the marketplace. And then, this ties directly into risk adjustment scoring, as even out of the public sector plans in terms of looking at how sick is the population, how can I most competitively rate the cost of the care in terms of taking on insurance risk, how can I share risk with providers accurately and actually give them a good picture, entice providers to share in risk because I'm giving them great information in terms of their ability to bet that they can take good care of these patients and still make a healthy margin to keep alive as a provider entity. And so the whole idea of risk scoring, is another thing. And then just again, getting into the ACO quality measures, being able to compete, being able to just meet your basic compliance requirements with the public sector programs around ACOs and manage Medicare, Medicaid, and then being able to actually affect the quality of the care, to share information with the provider network, because payers are looking at a large horizontal sample of patients. They can take a very big picture view that can then feed that information back to specific providers about specific patients, so they can say, hey, did you know this about your patient? Maybe there's something you can do, and here's a suggestion. So these are the drivers that are finally causing the payers to say, you know what, let me look at the HIEs, let me look at these private sources of information, let me go directly to the EHR vendors, let me find out how I can get at this information that people have been actively talking about for the last 5 years. So we see this happening, we see them jumping into the game, and we see a lot of our customers coming to us and saying, okay, what do I need to know? What should I know? And so we're trying to, gather as much information across the industry and feed that back to you. And that's the source of what the messaging is we're trying to share today. Next slide, Sergio. So, before you jump into it, some important observations that we've been able to make in talking to customers in the community and to providers and some of the standards organizations that we work with. There's kind of 3 dimensions that we see that drive successful activity or investments by payers. One obviously is willingness. We've heard a lot, and I've been in meetings literally with providers and payers where the providers are telling me those payers, they don't want to share information. And those same payers in that same room with those same providers telling me those providers, they don't want to share information. So there's still a big willingness conversation that has to take place and some barriers that have to be brought down. And those are, cultural, social, economic. I mean, there's a lot of factors that go into that. But that's not really so much about investment of money or in technology. That's really more about investing in relationships. And so there's, that's something though, investing in relationships is something that can be controlled by the payers and the providers when they have other incentives at play. And that comes into the other 2 dimensions of success here. There are, if providers are operating with, a more recent version of one of the more sophisticated EHRs, the Cerners, the Epics, the Allscripts of the world, the other usual suspects, they have pretty decent capability. Now they have to go a little bit beyond the EHR. They have to have some, what I'll call gateway capability. They have to have some connectivity. They have to have account management. So they need some fairly decent infrastructure in place to actually be able to carry out efficient, scalable, high volume, high speed information exchange with the provider, with their payer networks and partners, and with the payers with the provider network. So capability is certainly, something that's important. But sometimes what's more important than anything else is what's the value? If a particular payer, how many patients does a particular payer share with a particular provider? Because the volume and the types of patients, that case mix, that those two entities, the payer and the provider, they have a set of shared customers. If there's a very large base of shared customers, now there's a lot of opportunity to think about value. And the other thing that's important is maybe we share a lot of customers, but how much can the provider actually control? I think one of the observations we made, and it's a little bit controversial on both sides, but in my view at least, value-based care really only works when providers are given healthy incentives to do a good job at the things that they actually can control. And at the same time, though, they're held harmless for things they can't control. And if you think about a large IDS that may be covering 1 million members, they're more like an insurance company. They can take actuarial risk that, I'm going to win some, I'm going to lose some, but hopefully I'm just going to net out. But when you're trying to share risk with a provider who you may only share 1,000 or 2,000 or 5,000 or 20,000 patients with, there's a lot of random events, some random neonatal, 5 or 6 neonatal babies, or some high cost cancer cases in that population. And then suddenly, for things that are completely out of the control of the provider, a parent may be trying to share risk with them. And so it doesn't really work because the provider's being held accountable for things they can't control. And for the things that they can control, if you think about a provider that does a lot of joint therapy replacement, right? A joint therapy replacement proven, and this is recent data right from CMS, I think in the last 6 weeks or so, that there were huge savings in the small community of mandated joint replacement bundled payment contracts. And the reason is because once they were mandated, those providers were able to control the end-to-end cycle. The hospital was able to reach out to the pre-acute and post-acute providers, get a contract together, follow the patient from their first encounter through to their therapy and getting them back to work as early as possible, for example. And so that's something they control. They can actually give good care for that continuity and bundle. And so providers were able to actually put into place things that improve the quality, the value, the efficiency of the care, and then they were able to make money on their contract with the government. And so that capability of looking at the population that you're sharing with the insurer, between the insurer and the provider, and then being able to say, okay, what parts of the care can I control? What can I do? What can I measure? What can I provide value for? In many ways, and can you go to the next slide, Sergio? In many ways, that really is where you should be focusing when you start to initiate your information exchange with your network. The upper right quadrant, if they're highly willing, they're highly capable, and there's a lot of value, you're probably already doing information sharing between those payers and providers. Even if you're doing it in a proprietary way, you're reaching out and going, hey, we share a lot of opportunity here. You send me an Excel file, you send me a big access data dump, you send me a comma delimited CSV file. You're already doing that. But where the real opportunity is, if the provider has high capability and there's a high value opportunity that the payer and the provider can share around that common customer, then now you're just talking about willingness. Now you're just sitting down at the table and say, hey, maybe we don't like each other. Maybe we aren't comfortable sharing data. Maybe we think we're adversaries, but let's put that all aside because you've got a lot of capability, Mr. Provider, and I have a lot of value that I can gain share with you and give you a big upside. So this is something to consider, not just from the technology perspective of what you should be investing in, but thinking about your market. Go after that high margin, high value business, and those are the providers you should be reaching out to in order basically to get a fast return on investment for what we're going to be talking to you about, what we think you should be investing in terms of the kind of infrastructure you need. Hope that makes sense to y'all. Next slide. So the other thing to consider here too is when you're looking at, and Sergio's going to go into a little bit about what we think are some of the aspects, characteristics, dimensions of the technology infrastructure you should be looking at if you want to go down this road. There's been a fairly significant evolution in the types of containers, I'll call them, documents, methods that are being used for payers and providers to share information. Going back obviously into the 80s, we had paper charts. And so the real method to share was, short of making a copy and physically sending it, but faxing, creating PDFs, sharing that information really as an image document. Then HL7, going back 50 years, HL7 was in a lot of hospital systems in terms of being able to share information between the lab system and the registration system, or the lab system and the radiology system. So HL7's been around. That version 2 EDI capability has been around a long time, and it was heavily leveraged in the early days of HITECH and meaningful use, and the standards heavily relied on the version 2 cycle of HL7. Fast forward, a lot of the gaps that existed in those prior methods were worked on in version 3 and CDA and CCDA and now FHIR. We've advanced quite a bit in terms of our capability to move from document-based exchange to actually data element-based exchange, which is what you see in FHIR. The idea is, rather than give me a CCDA, give me a patient dump of a whole lot of information when the payer only needs a couple of little data elements. With FHIR, the payer is essentially able to ask for, give me those blood pressures, give me those A1C values, and then the FHIR standard can respond. Well, this is all well and good, but that's not where the industry is now. In many situations, you might have providers who are capable and willing, and there's a lot of value, but they're still going to be able to give you documents in PDF images or in the HL7 version 2 standards. And so whatever you're looking at, you have to be flexible enough to enter these arrangements with your providers to say, what kind of document can I handle? And just like your cell phone can handle MP3s or, Apple Music files or PDFs or 3 different versions of video files, and, essentially whatever document someone wants to send to you attached to an email, your phone can open it, right? So you want to think about being able to have that same kind of relationship with your provider network, that however they can send you this, you can find value in it, and you've got the tooling to be able to open it up and be able to deal with it without having to implement another whole entire stack of infrastructure, which is what we see a lot in the marketplace right now. Someone wants to solve their HEDIS problem. They go to a vendor and they employ an entire stack, top to bottom, vertical, that has everything as part of it, as opposed to saying, you know what, I'm already exchanging information. Why don't I leverage that same exchange network and then just focus on what I need to be able to do to read the document, interpret the document, and do something with the information. Next slide. So I think the last factor in terms of looking at, implementing some kind of architecture, capability, or portfolio of software that you need to do in order to do clinical information is think about that flexibility around the document and the flexibility around what you have to support in terms of volume. If you go down this road with these providers, you're going to start with, so many gigabytes of data. It's soon going to be terabytes of data, and it's going to be gigabytes and zigabytes and terabytes of data. So making sure that you're planning for that going forward, because whereas in the administrative side of the house with the HIPAA XTOL transactions, it's a very defined small amount of data that you have to exchange. You might exchange 50 million claims a year, but when you think about memory and storage and bandwidth, it's still relatively small compared to a lot of other information. When you think about going into the amount of data that's generated by patients in these EHRs, you're talking about orders of magnitude difference in terms of the volume and the bandwidth that you're going to need in the memory in these machines. So, whatever you do, it's not buy for tomorrow, but at least plan for tomorrow. And I think, again, I talked a little bit about the variety of the data that you've got to plan for. You don't want to have a separate information and technology stack for every different type of document you're bringing in. And then just the speed, how fast can you get the data from the point of service to someone who can actually do something, whether it's a UM team, your CM team, the data warehouse folks internally. How can you add the value that a payer has in terms of the 100,000-foot view of the world, and then be able to do something with the data and quickly get it back? So whether it's clinical alerts, whether it's interventions, whether it's observations on the population, whether it's feedback to the provider about how they're doing under their contract, so that I'm not waiting to half a year or full year and go, oh, wow, I did a really terrible job last year and now I'm going to take a financial hit. No, you want to be able to tell them day by day, week by week, month by month, hey, here's how you're doing against your contract. Based on the claims and clinical information I'm bringing in, here's a dashboard that says, you, Mr. Provider, here's your scorecard of how you're doing. So that before you get to the end of the year, you can say, wow, maybe I can do this differently, and that's going to put me back on track. And next week's dashboard is going to have me in the green instead of the red. So that kind of velocity is critical about the kind of infrastructure that you want to implement. So next slide. And with that, I believe I'm going to turn it over to Sergio to talk a little bit more about what this this infrastructure that we're describing looks like and how you might go down that road.
Thank you, John. So let me talk now about the solutions. And talking to our customers, payer customers, I would say we've encountered two kind of extremes of how payers are approaching solutioning the problems that John has talked about before. So one is what we call use case driven, and I'll give you like an example. Let's say a payer wants to implement claims attachments or prioritization attachments. So they will kind of focus on this specific use case, and then they will go back to their provider network. They will identify who the providers they want to work with for this specific use case. Wherever they can, they will leverage existing connectivity, or if needed, they will augment the connectivity to be able to solve this specific use case. And then, of course, they will, once they get the data, they will decide, okay, for this use case, I'll probably store in this system or that system. Maybe in case of claims management, claims attachments, they will probably store it in some document management system that they may already have or purchased. And then later on, as like an afterthought, they may think, okay, so we have this data, so maybe some other departments need it, so they will kind of start thinking, how can they share that document management system, or how they can disseminate that information to other departments on a need basis or on some more structured way. So that's kind of one way how our payer customers are approaching the problem. Is we call it use case driven, when they have a specific use case and they start solving the specific problem. The other extreme of the spectrum, what we've seen is a few customers have approached us and asking about a holistic approach. And what that means is they probably have gone back and they've determined what are across all their departments, what are the needs for the clinical information is there, and then they want to and some already are kind of in the process of implementing some of the aspects of it, is how to uniformly request this information from the providers. And they're also thinking about the fatigue from the provider perspective, so that they don't ask the providers again and again for the same information. So and then where do they store all this in some kind of a common store or common way of storing this data, and how do they disseminate this information to different departments that require that information? So very, I would say, different approaches to solve this problem. And we've seen a few that are looking to do some kind of a hybrid approach, where they start with some specific use cases, but as they solve those use cases, they always look at the big picture, and as they design the solution for the specific use cases, they try to design in such a way so that as new use cases come in, they all kind of fall into place, and it's not disparate systems, it's not different silos of data, it's all kind of fall into place. So as they implement all the use cases, in the end, they will get to this holistic approach. And if I were to compare these different approaches, there is, of course, pros and cons for each approach. And if I were to look at the use case driven approach, of course, there is a lot of pros. There is usually a very defined approved budget. There is a very defined clear owner of that kind of project. The requirements are very clear from get-go, and all the inputs, outputs, and the processing requirements, everything is very clear. So having all this upfront, of course, is a big boost to get the project started quickly and implement it in a relatively short period of time. Of course, the cons is very narrow scope of the use case, because only that use case has been solved. There is, of course, the problem with the provider dissatisfaction, because as more use cases have been built out, different departments are asking maybe for the same information multiple times, because these are all silos. There is no coordination between departments, and each use case, takes kind of a certain amount of time, money to build to solution. And as you add more use cases, you quickly will realize that overall the cost is actually much higher than if you were to go with the strategic approach. And the strategic approach, information exchange, the pros are very clear. It's a very scalable model. There is one store where everything is stored, and it positions the organization very well for data reuse, and for all kind of different usage of that data, of course, for the admin side, risk management, population health, all those different things that John mentioned before. However, it comes with some, I would say, cons or drawbacks. So first of all, we are talking about here is multiple departments being involved here. So there is no clear leader or owner of this. So it requires support from executive leadership. Usually the leader or the owner is most of the time in this kind of solution is the IT that needs to coordinate within various stakeholders, and this whole coordination is of course not that easy, and sometimes it's time consuming. And also it requires a lot of consensus, a lot of discussions between different stakeholders to get to the right solution for making this request and for acquiring all this clinical information. In the hybrid approach, the pros are the fact that we are benefiting from the use case approach. I mean, again, we have very clear defined requirements, ins and outs defined for each use case. There is very clear ROI for generating long-term value, because as the use cases have been solved, it's a very clear defined way to calculate the return on investment, to calculate the value of that solving that use case. And the hybrid approach also is scalable because it provides ability to extend the solution to solve additional use cases in the future. The cons of the hybrid approach is initially it takes longer to implement because some of the infrastructure items need to be put in place. Sometimes in the first use case, as you solve the first use case, it may require, because of that, it may require additional budget. And sometimes as you go along, as you implement the second, third, fourth use case, then it requires coalition between multiple stakeholders. So this is all nice, but as the payers implement or think about implementing the solution, they also have to think, like John mentioned, they have to think about the providers or the partners where they get the data. And like John mentioned, there is the capability matrix, and we try to kind of categorize them into like no tech, low tech, and high tech partners. And whatever solution the payers are building, it has to be able to meet the providers, the partners where they are. So if it's a no tech partner, they should be able to have portals, web-based solution, print drivers to be able to easily allow providers to print that data directly to the payer, a lot of web automation, workflows to help those providers that have no tech at all. For the low tech providers, they should allow exchange of the information using some kind of like direct email protocols or SFTP or some kind of a managed file transfer protocols to allow those providers to exchange information. And for the high-tech providers that understand and can support new emerging standards such as FHIR or Blue Button that already have integrated with multiple HAEs. For those providers also, payers have to have appropriate infrastructure to be able to meet them and be able to take advantage of these capabilities from the provider community. Another aspect as the payers design and look at the solution is to break down the problem, the big problem, to manageable pieces. As you know, there is a saying, how to eat an elephant, and the answer is, one piece at a time. So instead of trying to swallow the big elephant in the room, payers have to think about how to decompose the big problem to smaller manageable pieces. And we think if you were to look at the overall picture, there is the abilities or features around getting the data, then integrating that data, and then processing that data in some shape or form, and then vending that data to different departments. And when it comes to getting the data, of course, it matters what are the providers, what are the maturity capabilities for those providers, what the established connectivity models exist, or what new connectivity models need to be put in place, and of course the mutual agreement, the willingness, like John mentioned. On data integration, of course, players have to look at the supply chain mechanics, what kind of data they get from the providers, what quality, whether they need to validate that data, perform integrity checks, and also, of course, do the channel control, maybe educate the provider community to be able to, over time, to get much better data, quality data. Of course, there is need to be put some governance in place to do the information exchange, and also, of course, they need to be aligned on the semantics of the data. As you know, on the clinical world, you know, HL7, one HL7 is one HL7. I mean, there is disparity between, you know, code sets, terminology used. So it's important to be able to upfront establish what the data means, that the data being exchanged between providers and payers. What does it really mean? When we talk about data processing, of course, it's important at that point to be able to organize all that data, correlate that data, usually around the member or the episode of care, and then ability to derive more insight out of data and augment that data to create more value for that data. And then once these steps are done, then it's important to be able to report on that data, to create some kind of dashboards, to get insights from that data. You need to have some kind of capabilities to be able to look at that data and derive some kind of actionable insights and proactive notifications or inform the providers of some important things that are related to care. So that's where the timeliness of the data is important. And of course, at the end of the day is auditing of all this entire mechanism. So be able to audit exactly where the data came from, how it was enriched, all the consents in place, and how the data was disseminated, where it went to. So all this is of course important. So as the payers are designing this solution, it's very important to keep the big picture in mind. So even if you start with building a specific use case, it's very important to be able to always keep in mind what is the end goal, or what is the end architecture that eventually the payers will need to get there. And it's my belief actually that in time payers will get here, whether they get one approach of, you know, they start with just use case driven approach, or they start initially with the strategic thinking, because over time market forces will force the payers to get to some kind of optimization of their architecture. So on this diagram, data of course starts from the left side, where the partners, providers, labs, and so on. These are different sources of the data, and it's important to have one unified enterprise gateway, so that, like I mentioned, the governance of the data exchange is in place, the audit of that data, where it came from, and so on. So to get some consistent processing for that data. So enterprise gateway is an important aspect of the solution. And then the enterprise gateway should, of course, be able to get or able to process both structured and unstructured data. When I talk about unstructured, it's all the PDFs, images, and so on, whether it's coming from claims attachments or it's coming from labs, so it's coming all the different ways. For the unstructured data, of course, data most likely or needs to be stored some kind of enterprise content management system. But for structured data, payers need some kind of a holistic enterprise data information architecture to be able to store the data in a kind of uniform way, to be able to access that data in a uniform way, to be able to process the data in a uniform way. Of course, having both structured and unstructured information, having some kind of natural language processing or intelligent data extraction capabilities is key, because the more structured information you have, the more actionable insights you can get out of the data, more value you can derive out of data. The more you have just data in some kind of PDFs or unstructured formats, the less value you can derive from that data. Fewer use cases can be used, can leverage that data. And having that unified enterprise data information, if it's stored in some kind of a unified way, then you can apply you can have then different modules that can work on that data in kind of uniform way. So at the bottom you see different modules that we believe are important, and over time you may get all of them, but to start maybe you can start with some. So one important thing is like medical concepts normalization, being able to transform different concepts, let's say from SNOMED to LOINC to ICD code sets. Enterprise master person index is important because at the end of the day, all that data needs to be correlated around a member, a provider, to be able to derive insights. And of course, once that data is correlated around the member provider, you need to be able to build some kind of integrated patient record so that this information can be more easily disseminated to the destination systems. If you apply some kind of a machine learning or pattern detection, it's very important to be able to lower the cost of your intervention or be able to do a meaningful fraud detection. There's a lot of use cases around where the machine learning can really help. Having, of course, a correlation engine is important. And then if data is stored in one place, then it also helps to more easily do enterprise analytics, to be able to get insights from all that data. And of course, all that data needs to be able to be catalogized, indexed, so that a search engine can be put in place. So can somebody needs to look for information on John Smith, they should be able to get that information quickly, whether it's structured or unstructured. And you need some kind of data integration services, so to be able to transform that data into the destination format, whether you needed to disseminate the data to portals for your no-tech customers, or maybe to your internal business applications, or even share with external entities based on the need that you may have. So it's very important to have this keep this big picture in mind, even if you start designing a solution from specific use case. Another important aspect of the solutioning is, of course, you always have to think about value, and at each step of the way, just keep delivering value, because that is a key success for the solution, to be able to get this solution on a fast footing and to get success out of this initiative. And that involves, like I said, first of all, you need to be able to properly acquire that data, correlate that data, whether it's from disparate systems, different sources, whether it involves different protocols, ranging from no-tech to high-tech partners, being able to reconcile all that data and reach that data, whether it comes from claims or from HL7, from FHIR, it all has to come together. So once you acquire and correlate the data, then the next step, of course, is to improve your workflows, whether it's your internal workflows or external workflows. And of course, once you have that data, like I mentioned before, there is a huge opportunities to derive more value by getting what's called notifications or triggers. So getting insight from that data, to be able to intervene at the right step in the care based on the timeliness of the data, early detection of different problems with your patient population, and or let's say early detection of patient behaviors is another thing that can be leveraged by having the proper data at the right time. So with that, I want to turn on back to John.
Oh, thank you, Sergey. I'm sorry. I put myself on mute to be respectful and forgot. So anyway, thank you. Thank you for that summary of our view of on our learnings about what are the components that we think need to be part of any payer's implementation of clinical record exchange with their network. I think, Sergio, you had mentioned there was one little box on the bottom that you called the integrated patient record, and I just want to spend a minute to expand on that. There's a lot of folks that I'm sure everybody that is listening on this call have talked to this notion of the integrated patient record, the longitudinal patient record, the connected patient record, and to a great degree, there's value in a lot of the nuances that folks have talked to you about on that idea. But in many ways, when you look at the various incarnations of that, and you see a screen that says, okay, here's a representation of the patient's history, the longitudinal medical record. When we talk about the integrated patient record, and this is a little bit of a bias from we historically for 20 years have been really at the transaction, what I'll call the message level. And so our idea of the patient record is before it's been interpreted, before it's been analyzed, before it's been refined and aggregated and pushed into a data model, there's a concept we have that every message that comes in about your customer or your patient, your member, whether it's a X12 message, NCPDP message, HL7 message, FHIR message, whatever, each message has a source context, where it came from, who wrote it, how it got created. And having a early in the process capability to just assimilate those messages without any interpretation, almost what I'll call in the raw form, and being able to correlate those, all the, in a sense, the tribes, the various tribes within the clan, hold them all together and create a picture of your member, your customer, with all those messages in a line before they've been interpreted and pushed into a data model downstream in the data warehouse or the care management system or wherever. Being able to have a snapshot at a point in time and being able to look back at that and change your view on that and modify that, we believe that's really critical. No matter whose product you're using, having a staging area that allows you to pull all of the messages, all of the content that you've gotten from all of the people touching your customer in one place, get it correlated and organized and prepared for downstream use. In a sense, it means no matter how you change your internal systems, you can always go back to the original message. You're not going back to a second, third, or fourth hand account. It's the telephone game. I got a result in, or I got a visit summary, and then I've modeled it and I put it in one system, then I put it in the data warehouse, then I push it out to another system. It's a game of telephone. Being able to know what the original source was, where it came from, being able to correlate and having what I like to call a journal, a longitudinal journal of the interactions and the transactions that you have recorded over time about one of your customers. Having that repository, we believe, is really critical because it gives you much more flexibility as you evolve over time, over 1 year, 2 years, 3 years, 5 years, having your picture of that patient, where's the rest of me, as that cute little cartoon we had earlier, having that total view is critical. And kind of where we're coming at this from is if you, no matter where you are on the continuum, whether you're doing the use case approach or the strategic clinical data exchange approach, this is a picture that kind of a cartoon of what Sergio just presented. And, again, a little bit of bias here, but this may look familiar. This is characterized and labeled within the context of clinical data exchange, but it's probably going to look a lot like the architecture you have for your HIPAA transactions right now. So, our notion is where you've got a working network of communication between your payers and your providers, where I would argue that you already got a high volume HIE going on because you're taking in patient information, even if it's in X12 or NCPDP format. You're taking in tons of patient information, you're managing a relationship with the customers, you're governing the information in terms of validation and context and source and control and authentication and all that stuff. You've already got that infrastructure in place. So our notion is, rather than invest in new silos of infrastructure to solve specific business problems, look at the network exchange relationships you have with your providers right now, and then in a targeted way, augment that existing network with the components you need to interpret the data that's coming from that lost tribe. It's, you're already dealing with 11 tribes using an infrastructure. Why not just look at that infrastructure and say, what, if I add this, and this component, create this extensible clinical repository to house those transactions so that are HL7 or FHIR or whatever, And then I correlate those with the existing infrastructure. I've united the tribes. I've pulled everything back together without having to invent a whole new infrastructure. So this idea of ingestion, validation, correlation, and intervention, you're already doing it. You're already doing it with your existing network. And our thought is take a look at the pieces you've already got on the table, leverage those, extend those, and then be able to build out that clinical data strategy that you're all asking for and that we're hearing from you. So with that, next slide. So just, kind of as a summary, the things we're suggesting that you should be looking at is, think about an enterprise solution for exchanging a new tribe of information with your network, leveraging the components you have in place. Make sure that you're capable of managing multiple channels with that enterprise solution. Look for standards-based information exchange everywhere. If you think about the high volume exchange of information, whatever you're doing with anybody, employer groups, providers, customers, whatever, it's wherever you're really successful in digital connectivity, it's based on standards. It's not based on proprietary Excel spreadsheets and CSV formats. And then have a really good capability to manage the in and outs of the data, the supply chain logistics, because there's more fuzziness. Every X12 transaction is really a data model. Everybody knows what a referring provider is, what a rendering provider is, what a billing provider is. They know what the patient address is, the subscriber address versus the patient's address. Those are all well understood concepts in the X12 world. They're not well understood in the HL7 and the Fire world right now. We're still working with them until we've got lots of history, 3, 4, 5 years of history with managing that information. We won't, as a community, come to a common understanding of what each of those data elements means and how we each interpret them and how they were acquired in the first place from, Epic system at Dr. Jones. And then I think, we're going to see compliance and auditing become a bigger and bigger issue. One of the things that when we're looking at even just simple attachments, there's a lot of cases where payers are asking for more information maybe than they need. And a lot of times, even if they're asking for a small amount of information, the difficulty in providers, there's plenty of places where providers, if they're working on PDFs and they get a request for additional information, they send a chart. They send the whole thing because it takes so much time to go through an entire patient record and pull out exactly what the payer needs, that when they send it in, once we go to a digital world where all that's moving electronically, I can guarantee you that the whole notion of minimal necessary information is going to start to raise its ugly head. So having a really good ability to think about what you're asking for and what you're getting and govern that and make sure that you know who sent it, why they sent it, when they sent it, how you asked for it, all of those components, 2-3 years from now are going to be very important to you when this issue starts raising its ugly head. So with that, I think, we hope that this has been of some value to you. And we hope that you see that this, cute little metaphor is really about bringing together something that we separated from long ago when we started having a third party, and that now we're being challenged by that discrepancy. And the goal is to try to unite and get a full picture of the patient. So with that, I'll turn over. Any questions?
Thank you so much, John and Sergio. That was a great webinar. I want to encourage our participants, if you have any questions, please enter them into the questions field and hit enter. We already have a few from the presentation, so we'll get started with those. What's the difference between the current clinical data standards and the newer FHIR standard?
Sergio,
I can take that question. So traditionally, I would say, conceptually, they're more like traditional, they're transaction based. So it's more of a exchanging notifications or transactions, while FHIR is more on a need or more interactive, I would say. It's getting, instead of a payer or provider pushing that data to the payer, payer can just ask for specific elements of that data. So it's way more, I wouldn't say narrow, but more focused or specific way of getting the information. And that kind of gets back to what John was saying, that ability to get only what's needed, where needed, because of the HIPAA and privacy and so on, all these laws, that's what it's all important. But also because of the ability to be more proactive, more quick way of getting the information where the payer needs it.
Thanks, Sergio.
All right, our next question. Are there payer-specific use cases out there being designed by an industry group and used in production?
Sure, I'll take that. Yeah, interesting. That's a good question. There's a group called the Da Vinci Group, which if any of you haven't heard of it, it's probably something worth working on or worth investigating. You probably, and many of you have heard of, the Argonauts or the HL7 fire community, and largely coming out of the congressional inquiries into data blocking and some of the stories that came out about the HIEs. Those initiatives took off, but they still focus more on provider to provider interactions. What I think with the emergence of EBR and the desire of payers to get more involved in the clinical data exchange game, the use cases around things like quality reporting, EHR exchange, just benefits coverage. The idea that a provider needs to know at the point of service whether they need an authorization for simple stuff like that. Those specific use cases have kind of fallen to the back burner with delays in standards, new mandates and operating rules and whatnot. So those are emerging, and so the Da Vinci Group, which is kind of another subgroup under HL7, has come together. A lot of the major payers, providers in the country, some of the vendors we're a member, have come together to try to work on those specific payer-provider use cases around value-based care. It's an open community like the other HL7 groups. I would encourage anyone here to go on the HL7 website, look up Da Vinci, and see if it's something that you're interested in working with.
Thanks, John. Another question. How does HIPAA consumer consent play into this?
So most of what we discussed today, we're still under treatment, payment, and operations. Now, some of that is an extension that's based on the provider contract. So if they're taking risk and the provider agrees to share specific information about in order to get paid, then you're still under treatment, payment, and operations. I think that, as I kind of alluded to, though, if you want to keep leveraging that TPO exemption under HIPAA so that you don't have to worry about that, then you better start being much more clear. If you think about even just the emerging attachment standards and the use of LOINC codes, being able to know exactly what you want, sending that proper LOINC code to the provider to service the need, and having the provider be able to interpret the LOINC code and send you back exactly what you asked for, that's going to be important. As we go forward, with a lot of also EMRs, HIEs, whatever, are going to an opt-in or opt-out rather than opt-in. That's also going to start to raise some problems. The volume of clinical information being shared in HIEs was not going up very quickly until suddenly lots of states and lots of vendors started moving and providers going to opt out as opposed to opt in. And there's probably a lot of state legislatures that are still behind. They haven't caught up with that trend in the industry. But the amount of information being shared under Commonwealth and Direct Trust and some of these other initiatives has skyrocketed now that patients actually have to actively opt out. So I think this bears discussion, it bears watching, it bears involving your legal departments and compliance departments at the appropriate time. But as long as you stay true and aligned with your contracts, with your network, and as long as the providers are doing what they're supposed to be doing already under HIPAA, the things we've discussed today, you should be on solid ice.
And I want to add to what John was said, that as you're solutioning the system, and I already noticed that as I was talking to some payer customers, they also think about a module called like consent management, being able to really, as John was saying, as you get that data and you store it in one store, the raw original data, you should be able to trace back also not only what was stored, where it came from, but what was the consent related to that data, so that where the data can be or cannot be disseminated, or what can be done or cannot be done with that data.
So, well, I guess we're at 1 o'clock, Sam.
Yep, thank you very much, John and Sergio, for this fantastic webinar. Again, I will be sending the slide deck along with the link to the recorded webinar to all of our registrants. So thank you very much for participating, and I hope everybody has a great weekend.
Thanks very much, everybody.